prompted you once again to return to Guyana for this surgery?
I think there is a tremendous need for specialized form of surgery which was not present in Guyana. As you know from the past experience, we did the first kidney transplant in 2008, and the need was because there was a young kid who was going to die because there was no facilities, and dialysis is very rare. There are very few dialysis machines, and even if this kid could have got dialysis, he was only 17. It's very expensive. So for third world or developing countries, the way to go is not long-term dialysis, but to have kidney transplant. Unfortunately, in developing countries, people think that transplant is the highest form of surgery. It's very difficult with medications and so on and so forth. So they don't go into this form of surgery. The argument has been made by policymakers, including Minister of Health and so on, that this money should be diverted towards treating communicable diseases such as tuberculosis, typhoid, Kala-Azar, and typhoid, dysentery, and so on and so forth. But our argument is that these are young people, 20, 24, 25, and to see them die is also not fair, because for a small amount of money, this kid now has whole life ahead of him. He's married, he has a kid, he's contributing to the society. The same other patients we did, retired Major George Winston. He was in the army, he retired, he was on dialysis, but again he couldn't afford dialysis, and he was fading away, and his daughter came, gave him a kidney. And now actually he has become the coordinator for all other patients. So although he has a government job, he helps other patients as a social support system. The patient we are going to do this time is a 31-year-old, so he still has his whole life ahead of him, and he works in the bank, and his brother is a mechanic who has come forward. Now the government gives only finances for 10 dialysis sessions, which is 3 weeks. What do you do after that? And the cost of dialysis is very prohibitive in Guyana, as it is in other places. It costs about $200 for one session of dialysis. And the per capita income of Guyana is, I believe, $950 or something a year. So there is a big mismatch. So that's where we come in. And obviously we have to thank our colleagues and George and his colleagues, because they are the support behind all this.
Who are your colleagues on this trip at the moment?
So we have Dr. Stephen Guy, who's the chief of kidney pancreas transplant in Hanneman. It's now called Drexel University in Philadelphia. We have Dr. Art Womble, who is a colonel in the Army, is an anesthesiology provider in Birmingham, Alabama. We have Dr. Doyle, who's a nephrologist, trained nephrologist from Philadelphia, same Drexel University. One of my nurses, the operating room nurse is there. And we have a few local physicians who are willing to learn and help, although they don't have the training.
Can you tell us about events of the day of the surgery on March the 18th?
Yes, sir. We traveled down there on March 16th. On March 18th, after doing a dry run on March 17th, the team with Dr. Jindal and 5 other persons proceeded to do the kidney transplant with Mr. Gopinath Rampasad.
I understand his brother Kapil Dio was the donor. Can you tell me when you left there, and what is the current state of both the recipient and the donor?
They were in good shape according to the doctors, and from my visual observation, they were smiling. They were very happy, although we couldn't get to talk to them on a one-on-one, but they were smiling, a lot of waves and smiling and hand gestures like, saying okay and so forth. They were in good spirits. They were very happy. The family was there also, coming all the way from Krivitan, quarantine on Friday and Saturday. It's a successful surgery, according to everyone, including Dr. Balwant Singh Hospital, Dr. Jindal, and the doctors who did the surgery. They were so confident They left the following morning, and some others left on Sunday, and we left on Monday with Dr. Jindal and the nurse.
What kind of reception you received there?
Overall, it has been fairly good, because in the past year working with a public hospital, the needs are enormous. When you go to the clinic, you have about 500 patients waiting to see a doctor. Many patients don't even get to see a doctor. They go over disappointed. They come from 200, 300, 400 miles and they wait a whole day in the clinic and they will see. So there is a big need. What we are doing is probably a drop in the ocean. But what I see is, my role is to provide some hope to the patients, because we have done 5 transplants. We put peritoneal dialysis catheters, started the peritoneal dialysis program in 8 patients. We did some other surgeries. So it is a drop in the ocean. The needs are enormous. But when the other patients, the other doctors see that Guyana is being on the lower rung of developing countries can do this, it gives them hope and probably encourages other doctors as well. Our goal is not only to treat a few patients, to do transplants in few, save their lives, but also to prevent diabetes, hypertension, and early detection of kidney disease. So then a person doesn't go into kidney failure, doesn't require dialysis, eventually transplant.
How can we prevent it?
Prevention is by raising the awareness of diabetes, so regular health maintenance, prevention of obesity, early diagnosis. So that is how. So, and if the patient is caught early on in the disease process, hypertension, diabetes, or kidney failure, a few dollars worth of medications can delay the progression of both kidney failure and other complications of hypertension and diabetes, such as stroke, heart attacks, peripheral vascular disease, and eventually kidney failure.
What can you say about a service that you received at a private institution? For the first time, the surgery has been done privately in Guyana, not at the regular public hospital.
It was exceedingly very, very good. It was superb, as a matter of fact. After observation with other hospitals, as you know, we did check outside of the Georgetown Hospital, several hospitals in the Georgetown area. Dr. Balwan saying it was the best indeed. His place was clean, the people were receptive, they were cooperative, and they were hands-on. They show a genuine interest and want to make sure that this is successful. As a matter of fact, they promised and committed to see patients before we get there in future, and to continue to see these patients on an ongoing basis. And some of the doctors from overseas who works with him, like Dr. Chada and a few others, they have some experience in this area.
Is the rate in Guyana alarming, the amount of patients you've seen, or is it?
What I've seen is an enormous number of patients who require care, and because of the geography of Guyana, I think we are not even touching many regions. I think what we are touching is the region around Georgetown, and of course Mr. George Subraj, the owner of Zara Realty, he does a lot of philanthropic activities in terms of Guyana Watch and personal appeals and placing ads in the newspapers. But still it reaches, I think, probably maybe 5% of the population. So more needs to be done. And the second part is that there are no scientific studies to know what the incidence and prevalence is. So that requires epidemiological studies, which needs to be done as well. So only then we can say that in a population of 1 million, you have so many diabetics, you have so many hypertensives, you have so many patients with kidney disease, and so on. So this data will be useful for the policymakers, because the budget is small and they have to allocate resources, scarce resources. So that is one way. So it has to be a multi-pronged approach. It's not just surgery, but when we go, we give second opinions, we see patients. For example, one incident is a young, I think 22-year-old gentleman came to our clinic saying that he was diagnosed with kidney failure. And when we examined him, we found that he had adhesions because of previous surgery into his bowels. So what he had was pre-renal failure, but he was condemned to die because they said you require dialysis, and he did not have money for dialysis. So we took him to surgery, fixed the problem, it wasn't cancer, and he's fine now. So giving second opinion also helps.
How difficult is it for you to source help to come with you in terms of colleagues?
We are very enthusiastic colleagues who want to come. Again, we don't want to create a circus. We want to take a few people and do it well. So we have Dr. Guy here, Dr. Doyle. Before we had Dr. Falter, Dr. Elster, other colleagues. We have offers from Chicago, physician. Initially, people were reluctant, but now they see that we are doing something good and it's doable. We are getting approached. And also, the book I wrote on the first kidney transplant in Guyana, people have read that as well, picked it up, and newspapers, programs like yours. So it has created a positive feeling.
What can you say of the team? Dr. Jindal, Dr. Stephen Guy, Dr. Doyle, Dr. Orta Wumble, and Miss Tara Farley.
Dr. Wren he's an experienced surgeon, very tall man, always smiling. He wants to go back. Yes, he wants to go back and do more of these. He saw the need, and he was very happy with the cooperation he got from the Balwant Singh Hospital. Dr. Doyle, as you know, he's a professor of medicine. He's truly a nephrologist. He was seeing incoming patients and did some work with that, with the two doctors. But Dr. Jindal, as you know, this is his specialty. He was there from the beginning to the end and went back the following day and the following day, and of course until Sunday to see other patients.
In terms of the sponsorship, how important is George to what's happening?
George Subraj is a critical part of the whole endeavor because he does all the coordination, getting the local people involved, and also funding the effort. You require someone who can bring everyone together because I, being a physician, I don't have the talent or the time to do all this coordination.
Can you, in a nutshell, tell us what took place last September, October, November with Trey, the young man whose life was saved in Isla Cell?
He was a 21-year-old soldier who got shot in Afghanistan, and his pancreas was shattered. When he came to us, a small remnant, a small portion of the pancreas was left behind, and the option was to remove it because that's what was the standard teaching till then. But if he had removed the pancreas, he would have become what is called a brittle diabetic. That means within a few years, he would have developed kidney failure, heart problems, leg problems, and so on, besides a very poor quality of life. So what we devised was to take the pancreas out, make islet cells. It's a specialized technique with the University of Miami. We flew the cells back and put it in the liver. So although this technique has been done before, but not in this situation, and not in such a sick patient, because this patient had maybe 100 units of blood transfusion so far, was unconscious, was infected, and so on. So this was considered a major advance in the science of cellular transplantation. The paper was published in the New England Journal of Medicine, which is the highest impact factor journal. And since then, we are advancing the program to take more patients in a similar situation.
Did you see more patients, or is this the end of what you've been doing?
Yes, there are about 8 or 9 patients lined up for future surgery, and we intend to do this on a case-by-case basis. Next lined up is Mr. Green, Sharma Green. It's a young 22-year-old boy. And then we have another girl that's 20-something, and a gentleman from the interior, Mr. Roberio. He's also slotted to be, and they're all getting up there in age, Mr. Roberio, but more and more we can able to do this here from what we're seeing. The local people are very cooperative and are participating with us, especially those at Dr. Balwant Singh Hospital.